human health. Now, please excuse me if I happen to have a cough or a coughing fit, God forbid, during this live, because I have got some respiratory stuff going on today. So maybe we should be doing a respiratory chapter. But anyway, so just with that out of the way, this is a really exciting chapter because it is about my favorite topic, which is gastrointestinal health and nutrition, with a focus obviously on therapeutic carbohydrate restriction, because that's what this book is all about. There are three authors on this chapter, myself being one of them. But the main author is Natasha Campbell McBride, who is very, very well known for her books and her work on the gut and psychology syndrome, or the GAPS diet. So you may know her for that. She graduated with an honors as a medical doctor in 1984 from a university in Russia. And in the following years, she gained a postgraduate degree in neurology, after which she practiced as a neurologist and then a neurosurgeon before she started a family and moved to the UK. In the UK, she completed a second postgraduate degree in human nutrition at Sheffield University, specializing in using a nutritional approach as a treatment for mental disorders, learning disabilities, as well as digestive and immune disorders. And in 2004, she published her very well-known, in over 20 languages, book on gut and psychology syndrome, which is a term that she herself coined, which is basically all about the natural treatment using diet of mental conditions, including autism, ADHD, dyslexia, dyspraxia, depression, and schizophrenia, which explores the connection between patient physical state and the brain function. She's also a member of the Society of Authors, the British Society for Environmental Medicine, and a board member of the Weston A. Price Foundation. She's also a regular contributing health editor to a number of journals, magazines, newsletters, and radio programs around the world. Unfortunately, this main author of this chapter couldn't make it to be with you today. So Sarah and myself, her two minor co-authors on the chapter, will take you through the chapter, tell you what to expect, and discuss a little bit in a little bit more detail what she covers as well as what we cover in the chapter, so that you know what to expect. So that leads me on to the next author of this chapter, Sarah Rice. It's wonderful to have Sarah Rice here. Welcome, Sarah.
Thank you.
Sarah is a certified nutrition network medical practitioner, editor, and contributor to Ketogenic, the Science of Therapeutic Carbohydrate Restriction in Human Health. So she's not just an author, but she is also an editor of this textbook. And she's also a member of the Society of Metabolic Health Practitioners. She qualified in the UK as an optometrist and worked in private practice and NHS hospital eye service. She now lives in Cape Town, South Africa, and she's currently focusing on researching and curating references that support clinicians' use of therapeutic carbohydrate restriction to help improve metabolic health as an adjunct to disease management. And not only really does she curate references, but she's also very good at editing medical writings, such as this textbook. And she has an incredibly fastidious eye for detail. So nothing gets past Sarah. It's wonderful to have you, Sarah. Thank you so much for joining us.
Thanks, Tamsin. Great to be here.
Great to have you. So I am Tamsin Murphy. Many of you will recognize me and know me. I'm a registered dietitian with a master's degree in physiology from the University of Cape Town in South Africa. And in that degree, I investigated low carbohydrate diets in type 2 diabetes. I have experience in research and development of nutritional supplements. I have experience as a book author, as a nutritional editor for a well-known health magazine in South Africa, as well as 6 years of experience in clinical practice with therapeutic carbohydrate nutrition in dietetics practice. I currently work at Nutrition Network as a content editor and a lecturer. So it's wonderful to be here. I was also one of the editors alongside Sarah of the textbook Ketogenic, the Science of Therapeutic Carbohydrate Restriction in Human Health. So it's wonderful to be here discussing my absolute favorite pet topic of gastrointestinal health. So let me start by telling you a little bit about this chapter. It's kind of self-explanatory. Obviously, we've got therapeutic carbohydrate restriction and we've got gastrointestinal health. So that's what it's about. But we go into the microbiome, obviously, because that is such a crucial central component of what makes a healthy gut. And or an unhealthy gut if it's dysbiotic or dysbiosis in the gut. And Sarah ends the chapter off writing a brilliant section on this topic. But that's not all that this chapter goes into. It starts out with looking at diet specifically in gastrointestinal disorders. And in this section explains how different nutrients are digested and absorbed and the impact that they have on health or on disease. So here, Natasha Campbell-McBride goes through things like protein, fat, carbohydrate, fiber, alcohol, and how each of those firstly, how they get digested and absorbed, in what parts of the gut they get digested and absorbed. So in that way, the reader gets introduced to normal physiology of the gastrointestinal tract and nutrition. And then she goes into what happens when the digestion and absorption of these nutrients or of these dietary components goes wrong. And what could be causing that. So things like, for example, fiber. She'll go into, this is how fiber gets processed in the gut, and these are the potential outcomes of having too much fiber, having too little fiber, and having fiber in the context of different diseases or conditions. So that's kind of what we go into first. And I'm going to chat to Sarah a little bit about fiber because that impacts on the microbiome as well. And it's quite a contentious topic. So when we dive into a few of the topics within this chapter, we'll talk about that. The next section of this chapter is called Guiding the Patient. So this is the practical implementation of the physiology that was discussed in the first section. So this is actually Natasha Campbell-McBride gives you food lists belonging to her GAPS diet, the Gut and Psychology Syndrome diet, which incorporate common aspects of the most evidence-based diets for gastrointestinal disorders, such as IBS or inflammatory bowel disease. And these are specifically specific carbohydrate diets and low FODMAP diets and Paleolithic diets. So she combines these diets together with her clinical experience to come up with food lists to actually help clinicians to have a starting point that they can help guide their patients in the right direction of what to eat. Obviously, she does emphasize that there is individual variation. So some people are going to be more sensitive to certain foods or certain nutrients than others, and that is individual and requires clinical guidance as well as personal or patient record keeping and that kind of thing, elimination diets potentially. This is not straightforward, but at least in here, there is a food list of what foods to avoid for most people based on the diets that work for the most common gastrointestinal conditions, and what foods to avoid for these for people based on these conditions. And Sarah, if you want at any point interject, please do. You're very welcome. If you want to add to something I've left anything else, because Sarah knows this chapter very well. Both of us were very involved in editing this chapter. So then she also goes into dietary approaches then to address specific gastrointestinal conditions. I'm just quickly seeing if I can change my view to gallery. I'm not entirely sure how to do that on here. Okay, so I'm going to just continue. So the dietary approaches to address specific gastrointestinal disorders are discussed, and these would be what kind of diet are you looking at for irritable bowel syndrome? What kind of diet are you looking for inflammatory bowel diseases, such as Crohn's and ulcerative colitis? What kind of dietary approaches for diarrhea or constipation? So these kind of topics are all discussed as well, very practically. And then nutritional supplements are also discussed towards the end of the chapter. So this is the last bit that Natasha Campbell-McBride talks about, and that is nutritional supplements such as probiotics. Where do they fit in? Where do digestive enzymes or bile salts fit in, for example? And she evaluates the evidence, combines that with her clinical experience and her research to come up with recommendations. And remember that every single chapter has been very closely reference checked, fact checked, and the references, every statement is referenced. So the reader can go to something and say, okay, well, what is the evidence for this? and you'll be taken to the evidence if you follow the references. And Sarah has checked every single one fastidiously. Absolutely amazing, very hard work. We also had an intern from the US who did amazing work on this section as well, Kelsey Mabry. And then we finally end off the chapter with the microbiome. and Sarah takes us through that. So now I think let's start diving into a few of those aspects. And if anyone has any questions, you can please feel welcome to drop them in the comments section, and we can get to them during this discussion. Also, just to note, this discussion is a short one because Dr. Campbell McBride is not here, so we will be keeping it to the next 10 to 15 minutes. All right, so I think let's start with looking at carbohydrates, because this whole textbook is about therapeutic carbohydrate restriction. And one of the very well-known carbohydrates that is purported to be good for gut health is fiber. Fiber is a carbohydrate. It is just not broken down fully in the gut and not fully absorbed or not fully digested either. So I'm going to quote a quote from Dr. Campbell McBride's chapter regarding the large intestine, where she says, part of the research has focused on prebiotics, which we all know they're very well known for being good for the gut because they are food, it's fiber, food for the probiotics, which are the bacteria that live in our digestive tracts. So part of the research is focused on prebiotics, carbohydrates which feed bacteria. Prebiotics, starch, and fiber are considered to be good food for bacteria in the gut. Again, the focus is only on bacteria for these. However, clinical experience shows that these substances feed equally the good and the bad microbiomes in the gut, and fungi in particular. If one has a healthy gut and a balanced microbiome, it will feast on the starch, fiber, and prebiotics, grow larger colonies, and make one healthier as a result. However, if the gut is dominated by pathogenic microbes, then they will feed on these carbohydrates and make the person very sick. So, in other words, if you're providing bacteria with food, let's hope the bacteria in there are predominantly good bacteria who will grow rather than bad bacteria. And then she goes on to say, in people with serious digestive disorders, prebiotic starch and fiber may have to be removed for a long time to change the gut flora and heal the gut lining. And there are obviously references for these statements. Now, this is not the only spot where in this chapter we talk about fiber being good for the gut, yes, but also potentially not great. Sarah, could you weigh in either from the perspective of the microbiome or from any other perspective on your thoughts regarding fiber?
Yeah, I mean, if I can just start by just giving an overview of what I looked at, and then I will get into that aspect. I mean, the microbiome is really exploding in interest. I think I've seen papers commenting on connections between microbiome and health to almost all disease states. And the challenge, I think, is what to do with it, especially where metabolic health plays a significant role in all these conditions, and it is bidirectional. So the section that I sort of did on the microbiome, I just pulled out some concepts. I mean, the first point was, can we say what a healthy microbiome looks like? And Dr. Campbell McBride sort of alludes to the fact that there are lots of challenges in microbiome research, to the point that it really raises issues of clinical utility. One of the factors is that there are so many factors that influence the microbiome: the birth history, maternal microbiome, geography, culture, toxin exposures, exercise. So many factors influence it, and it could be that those with a more compromised exposure history, they might be more sensitive. So in short, the trends that we see in the microbiome are context dependent. So ratios of healthy to harmful bacteria and their byproducts drive a lot of the benefits and issues. So as you've alluded to, carbohydrates, specifically, we're talking about the fermentation of non-digestible carbohydrates to produce short-chain fatty acids and butyrate. You know, that drives benefits, and it's known to be associated with insulin sensitivity. But if you have overgrowth of E. coli, you can get an increased levels of TMAO, which might be problematic. So we've got diversity and butyrate producing bacteria as being important. But if I just skip ahead here on my notes, so the discussion around non-digestible carbohydrates is really because bacteria ferment these, and then it's associated with health markers, or we see that in healthy populations. And so people get very excited about this and the fiber, but we also know from other studies that the protein can also produce short-chain fatty acids, slightly less butyrate, but also does produce a similar short-chain fatty acid in the form of isobutyrate. And also, if you eliminate carbohydrates from your diet and you go into nutritional ketosis, you have ketones produced by the liver, which also support gut health. And this can provide adequate fuel for the gut epithelium and promote gut healing in the absence of irritants. So Dr. Sean Baker's chapter alludes to the anti-nutrients that can be found in plants, and that in sensitive individuals, these can be problematic. But we do see this particular paper by David et al., which is in the section and can be looked at with animal-based diet, you can produce enough short-chain fatty acids to promote gut health, and it's equally offset by ketones produced by the liver. Is that
great? Yeah, that's great. Thank you so much. So basically, Sarah, what you're saying is, well, I think I'm gonna layperson it a little bit, or kind of summarize it. So basically, what has been thought to be really helpful about fiber, or prebiotics or prebiotic fiber in the gut, is that it is broken down into these short chain fatty acids, namely butyric acid or butyrate, or its variations of that. And this compound, the short chain fatty acid that gets broken down by bugs in the gut to produce, basically it's from a carbohydrate. So it's a carbohydrate. Fiber is a carbohydrate. It gets broken down into a little fat, which then feeds the intracytes, or the lining of the gut, which has been associated with a lot of health benefits. It not only does that, but then some of it passes through the gut wall, not very much, and then it goes into the bloodstream, and it has benefits there as well. Now, if you hear the word ketones, not everybody realizes that ketones are also short-chain fatty acids. So, fiber gets broken down by the bacteria in our gut into short-chain fatty acids, but our body makes short-chain fatty acids, which are almost the same, just by the process of ketosis, by converting generally mainly fat, but also protein, can be converted into ketones, these short-chain fatty acids. And one of them is butyrate, beta-hydroxybutyrate, which is very much the same, or very similar to butyric acid, which is the one that's been shown to have benefits in the gut. And it's one of fiber's main kind of purported benefits, or mediators of its benefits. So what Sarah's saying is that basically, when people eat a ketogenic diet, they make enough, or an animal-based diet, in the reference that you referred to, Sarah, they make enough of the short-chain fatty acid that it has just the same benefits to the gut lining and elsewhere, and potentially more, because it looks like there are actually higher concentrations circulating in the blood when you do a ketogenic diet than you would if you're just eating fiber and it's getting broken down in the gut. So there are going to be higher short-chain fatty acid concentrations in the blood of someone on a ketogenic diet, and also the same amount would be accessing the intracytes from the gut, but from the inside, and so similar benefits would be expected. Could you tell us a little bit more, Sarah, about the contextual nature of the microbiome? Because some people say, well, a healthy microbiome contains these bugs or these bacteria, and it changes when you go onto a therapeutic carbohydrate restricted diet, and therefore it can't be healthy.
Yeah, so there was another paper which was really interesting by Scholl et al. And he and his team just expanded on this concept of your metabolic flexibility, and that the microbiome that you're looking at should be evaluated in context with your fueling system. So if you are in nutritional ketosis, you are getting ketones that are being made from the liver, which contributes to that fueling system and how the body is running. And we know that it attenuates and is helpful for healing, and your whole body system is running completely differently. When you are eating carbohydrates, a higher carbohydrate diet, perhaps then the short chain fatty acid pathway that you are fermenting those non-digestible carbohydrates, they become more important. So you would expect the microbiome to look different for somebody who's over consuming a diet that's higher in carbohydrates and is comfortable doing that. And if their microbiome is in balance and the right bacteria are being fed, then that can be a healthy state for some people. But then conversely, when you're in nutritional ketosis, your entire fueling system and all your pathways are different. And so it's reasonable to expect that the gut microbiome is going to be different, and you're going to have different byproducts of those metabolites will be different. So another feature that he mentions is lipopolysaccharide, which can enter into the bloodstream if you have a leaky gut. That particular toxin is neutralized by HDL, which we know is elevated generally when you're on a diet that's a therapeutic carbohydrate restriction. Normally you get a healthy elevation of HDL. And so that also has benefits in dealing with that bacterial endotoxin. And obviously, if your gut is in a healthier state and your barrier function is optimal, then you're less likely to get LPS as being a challenge.
Great. Thank you, Sarah. So it seems like, the microbiome is contextual, like many things. For those of you who joined the talk, that the discussion that I had earlier this month with Amber O'Hearn, we talked about the contextual nature of micronutrients. And I think this just emphasizes again that everything is contextual. And what a healthy gut is for someone eating a high carbohydrate diet is not necessarily going to be a healthy gut for someone who's not eating a high carbohydrate diet. And that's evident from, the first fecal transplants that happened to treat Clostridium difficile infection. And that was done in the more native tribes in Africa. So Western people who had this infection would go to the native tribes to get fecal implants done there because of the healthy gut microbiome or the healthy gastrointestinal flora that the tribes had, yet these tribes eat relatively low carbohydrate diets. So while they won't have as many microbes that are going to be processing carbohydrates because it's just not appropriate. They will have a different kind of gut. And there's studies also showing that when people first go onto a study I recently read on MS, people with multiple sclerosis, who go onto a ketogenic diet, and they looked at their microbiome, and it looks like in the first few weeks, or especially initially, the microbiome, the diversity and the quantity reduces significantly, but by the 6-month mark, it has the microbiome diversity has increased far beyond what it was at the start of the study, and the quantity of beneficial microflora has also increased alongside beneficial symptoms. So that kind of shows you that sometimes people are observing a reduction in diversity and concentration of microflora when people go onto a ketogenic diet, but similar to how you would see a reduction in exercise capacity within the first 3 weeks on a ketogenic diet, or you might see keto flu on the first week. These are acute symptoms, and what we really should be interested in, if this is going to be a lifestyle, what are the long-term effects of eating this way on the microbiome and on the gastrointestinal health. And I think studies coming out are showing that, yes, it might look different, but it is beneficial. So yes, Sarah.
I'll just interject slightly. So we also see that we've seen 3 case studies where we've seen a reversal of SIBO, small intestinal bacterial overgrowth. We've seen that reversed on a 0 carbohydrate diet. I think there's about 3 case studies. So again, that's a movement into a healthy space. And I believe those case studies demonstrate there was re-challenge. So they were able to reintroduce some carbohydrates after a time of healing. So it just also speaks to the time frame. You would expect that your gut is going to take some time to heal. And for some people, they may be able to reintroduce those carbohydrates that were irritating when their gut was not healthy. And for others, perhaps, who continue to be on that spectrum of being sensitive to plant material. And that's kind of what I always say to people, because not to focus on one particular vegetable or whatever and associate it with health per se. Just eat real food and take note of how you feel. How does your gut feel? And be guided by that. And if necessary, one may need to go towards an exclusion protocol.
Great, thank you, Sarah. And I think that is actually a point that is emphasized throughout this chapter, is stay away from processed food, eat real food. And not only in this chapter, but also throughout the textbook. I think if there are 2 key messages, it really is eat real food and stay away from processed food. And just before closing, I wanted to talk a little bit about the small contribution I made to this chapter, which was regarding diets in particular. Therapeutic carbohydrate restricted diets, or they might not be called that, but what do diets have in common that have benefit for a variety of gastrointestinal disorders? And after scouring the literature, it appears that all of the ones that have benefit for disorders such as inflammatory bowel diseases and irritable bowel syndrome is that they somehow modulate carbohydrates. So, for example, the one with amongst the best evidence for inflammatory bowel diseases is something called the specific carbohydrate diet, which avoids all dye and polysaccharides, which are hypothesized to be poorly absorbed in inflammatory bowel disease and then result in overgrowth and then damage to the gut, right? There is a variation on that called the anti-inflammatory diet, which again limits certain carbohydrates. And these 2 diets are the ones that have the best evidence for benefit in people with inflammatory bowel diseases. Now, what is the diet that has the best evidence for people with irritable bowel syndrome? Well, it's the low FODMAP diet. And what are FODMAPs? They are fermentable carbohydrates that aren't very well digested and absorbed and result in gas and symptoms in IBS patients. And when people with irritable bowel syndrome, IBS, limit FODMAPs, in other words, these fermentable and poorly absorbed carbohydrates and polyols, to less than 50 grams per day, they get improvement in symptoms of gas, bloating, distension, pain, and motility in 74% of IBS patients. Now, what is a ketogenic diet by definition? It is limiting carbohydrates to less than 50 grams a day. So by definition, the fermentable ones will also be below 50 grams a day. So a ketogenic diet is actually a low FODMAP diet. It is. It also is a specific carbohydrate diet and an anti-inflammatory diet because it avoids dye and polysaccharides, really. So my point that I make in my little box in this chapter is that the commonality of the best evidence-based diets for the biggest bowel diseases or disorders, which I've focused on inflammatory bowel disease and IBS, are carbohydrate restricted diets. And so it makes sense that a ketogenic diet or a therapeutic carbohydrate restricted diet would also improve these. We just need more research. And the research is happening in this area, but it is still an area where a lot more research needs to be done. So I just wanted to end with that, which I think is actually really, really important in this section, that is a commonality that runs through the diets. that have the best evidence for their efficacy in gastrointestinal diseases. Yes.
Yeah, and sort of undisputed really is that many components of the Western diet are highly problematic. So I think in my section, I noted about 70% of the US diet is comprised of processed foods on a daily basis, which are acellular, containing preservatives and artificial sweeteners and oxidized oils. So, I mean, the entry level therapeutic carbohydrate restriction kind of point is removal of ultra processed foods from your diet. And I don't think that's controversial at all.
Not at all. Thank you, Sarah. So we're going to leave it there. There is a lot more in this chapter that we have not covered. But thank you all very much for listening. And we hope that you enjoy the chapter as much as we have. And we look forward to speaking to you again tomorrow about chapter 9. Thank you, everybody, and have a good morning, afternoon, and evening, wherever you are. Thank you, Sarah.
Thanks. Bye-bye.
Bye.